Hi, Mike Gibson, Mikhail Kosiborod, and we're talking about a participant-level analysis of all the pooled data from trials of semaglutide in patients with heart failure and preserved ejection fraction. Mikhail, tell us a little bit about what you did and what you found.
Well, thanks, Mike. Always good to be with you. The backdrop really for the study is that we know that heart failure with preserved ejection fraction is not the most common type of heart failure. We know these patients experience high risk of clinical events like hospitalizations and urgent visits for heart failure, high risk of cardiovascular death, and also high burden of symptoms and physical limitations. And we know that 80% of patients with what we call commonly HFpEF are living with overweight or obesity. And of course, some of the recent developments in the trials that we've done, trials of GLP-1 receptor agonists such as semaglutide, was to try to understand and, in fact, prove that, in fact, obesity is not just a comorbidity. It doesn't just accidentally happen to coexist in these patients, but maybe in many of these patients, obesity is actually what's driving the development and progression of heart failure to begin with. And what we showed in the STEP-HFpEF program, which had two trials, STEP-HFpEF and STEP-HFpEF diabetes, both in people with obesity-related HFpEF, in one trial without diabetes and the second trial with diabetes, is that semaglutide as compared with placebo led to much larger improvements in patient symptoms and physical limitations and quality of life, and much larger increases in exercise function. And it also led to a significant reduction in body weight and biomarkers of inflammation and congestion, natriuretic peptides and CRP. So the heart failure events such as hospitalizations, urgent visits, and cardiovascular deaths were adjudicated in those trials, and we analyzed them, and there was clearly a signal towards fewer events, but the number of events was very small because these trials were not powered for clinical events. They were relatively modest in size, and they were relatively short in duration. And so even when we combined the two trials, there was clearly a signal, but it was based on very few events. So to this day, it's not known definitively whether, in addition to improving symptoms, physical limitations due to heart failure and exercise function, whether semaglutide can also reduce the risk of clinical events. And of course, that's a critically important question. So what we did in this analysis was to pool the data from STEP-HFpEF and STEP-HFpEF diabetes, but in addition, from larger trials of semaglutide that focused on other patient populations, but also included patients that had HFpEF at baseline. So that includes first and foremost SELECT, which was a very large, more than 17,000 patient trial of semaglutide versus placebo in people with overweight or obesity and atherosclerotic cardiovascular disease, and also FLOW, which was a trial of semaglutide in people with diabetes-related CKD. So both of those trials, SELECT and FLOW, were event-driven, large outcome trials. And in both trials, obviously you have the same drug, semaglutide. You have the same comparator, which is placebo, as what we did in STEP-HFpEF trials. But importantly, in both of these trials, investigators were asked to identify patients with prior history of HFpEF. And we also had pretty complete data on NYHA class and on echocardiographic assessment of ejection fraction in a vast majority of these patients. And so what we did in this analysis is essentially identify these people that had HFpEF and SELECT and FLOW, and essentially do a pooled patient-level analysis of those patients combined with STEP-HFpEF and STEP-HFpEF diabetes, which ultimately comprised more than 3,700 patients with a prior history of heart failure and preserved ejection fraction. And the main outcomes we looked at were the effects of semaglutide versus placebo on a composite of cardiovascular death or heart failure events, hospitalizations, or urgent visits due to heart failure, as well as heart failure events alone and cardiovascular death alone. And we also looked at safety. So what were the main findings? I think the bottom line is we observed a significantly lower risk of cardiovascular deaths and hospitalizations for heart failure with semaglutide versus placebo. In fact, there was a 31% relative risk reduction in those events, highly statistically significant. We also saw a even larger reduction in terms of relative risk reduction in heart failure events alone. So if you look just at heart failure hospitalizations, urgent visits, the hazard ratio was 0.59, so 41% relative risk reduction in heart failure events. When it came to cardiovascular death, the hazard ratio was favorable to semaglutide, 0.82, so 18% relative risk reduction, but it did not reach statistical significance because the number of cardiovascular deaths was relatively small. Finally, when it came to safety, we saw that use of semaglutide led to fewer serious adverse events, quite a bit fewer serious adverse events than use of placebo. And that was driven predominantly, as in individual trials, due to fewer serious cardiac disorders, including in large part heart failure hospitalizations. So I think the bottom line message here is that with this pooled analysis of 4 different trials and 3 different trial programs, we now have complemented quite substantially what we knew from STEP-HFpEF trial program, which is that semaglutide doesn't only improve symptoms and physical limitations and exercise function in this patient population, but also leads to fewer clinical events in a very compelling way, including cardiovascular deaths and heart failure events, and as well as heart failure events alone.
Wow. Well, congratulations. Important news. Of course, if you lose weight, you're going to feel better, right? You're going to get around better. But this really says that it's more than just improving your physical limitations with weight loss. You're really improving heart failure, which is very important. You said you improve your biomarkers, which again speaks to the mechanism of action here. Mikhail, what do we know about the fundamental mechanism? Is it just related to weight loss? Or is it related to an effect of semaglutide itself as a drug, on the process of heart failure? What do we know there?
Yeah, I think we have multiple lines of evidence now indicating that it cannot be fully explained by weight loss alone. So we think that in heart failure, at least, weight loss is an important factor. But, everything that we see so far suggests that there are mechanisms other than weight loss that are at play here, and then there are direct decongestion or decongestion-driven effects of semaglutide that are truly disease-modifying and directly on the pathobiology of heart failure. So why do I say that? Well, let me give you just a couple of examples. First of all, we know that there are, well, at least in terms of symptoms and physical limitations, and in fact, we also see that in this analysis on clinical events, there doesn't appear to be much treatment effect heterogeneity or treatment benefit heterogeneity. All patient subgroups do better, more or less, but there are some types of patients, when it comes to symptom improvement, for example, that do even better. And those people appear to be those with more advanced heart failure. So people with higher NYHA class in the STEP-HFpEF program, people with higher NYHA class, people with higher natriuretic peptide levels, people who are on loop diuretics versus not, people who have atrial fibrillation versus not. So for all of these factors suggesting more advanced heart failure, while patients who don't have these factors benefit from semaglutide, those that are more advanced benefit more than twice as much in terms of symptom improvement and physical limitation improvement, but yet they lose the same amount of weight as everybody else.
That was what I was going to say. When you adjust for weight, equal
amount
amounts of weight loss, is there a difference there? So it's saying, yes, it's not all just weight.
Yeah, same amount of weight loss, but much greater benefits in terms of heart failure symptoms and physical limitations. The other piece of evidence that we have is, contrary to what conventional wisdom would predict, right? Because semaglutide induces pretty substantial weight loss. one would have predicted that NT-proBNP levels would actually go up because we know that with loss of adiposity, natriuretic peptides go up. However, what we saw in the STEP-HFpEF program is that NT-proBNP levels went down, and they went down significantly. And in fact, the degree of reduction in NT-proBNP, as we've published and demonstrated now, is independent of weight loss. So semaglutide lowers NT-proBNP. It doesn't matter if you lose less than 5% of body weight in a trial, or whether you lose between 5 and 10%, 10 to 15%, 15 to 20, or more than 20. For every one strata of these weight loss categories, semaglutide significantly reduces NT-proBNP as compared with placebo. So first of all, so I would say NT-proBNP reduction is both independent of weight loss and also occurs regardless of weight loss, which again kind of decouples the effects of semaglutide from weight loss itself. And then the last one is we now have echocardiographic data from STEP-HFpEF as well. We had very large echocardiographic sub-study, and we see clearer remodeling effects on some critical components, including reductions in left atrial volume, including improvements in diastolic function, and also some effects on right ventricular remodeling as well. So there are now multiple lines of evidence indicating that it's truly disease-modifying therapy. It's not just simple mechanical unloading from weight loss.
And those improvements in the echo parameters are independent of weight loss, I assume, as well, the magnitude of weight loss?
It depends, but there is some relationship between reduction left atrial volume and weight loss, but that doesn't necessarily mean that weight loss explains all of the remodelings that we see, of course. So I would say, you know as well as I do that kind of distilling the mechanisms in clinical trials is not an easy undertaking, and it's fraught with methodological difficulties. But I think, as I kind of just went over everything we know so far, while I think weight loss is a part and parcel of what's happening, there are clear multiple lines of evidence suggesting that weight loss alone cannot explain everything we see here.
No, thank you. What an advance. Thanks for taking time out and sharing with us. And thanks to all of you for joining us here live from ESC 2024.
My pleasure.